Each prescription starts with good intention, but over time, they can begin to add up in ways that really impact our quality of life. And as we age, we may find that our medication list just keeps growing longer and longer. So how do we know when medications continue to help and when they could be causing harm? And how can we thoughtfully simplify care while still protecting our health? This is Aging Forward, a podcast from Mayo Clinic about the science behind healthy aging and longevity. Each episode, we explore new ways to take care of our long-term health, the health of our loved ones, and our community, so we can all live longer and better. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota. And today we are talking about polypharmacy and the art of deprescribing. Joining us today is Dr. Bonnie Sohn. She's a geriatrician at Mayo Clinic in Rochester, Minnesota, an outpatient clinician, and an award-winning educator. And as someone who knows her personally, I have seen how deeply committed Dr. Sohn is advocating for her patients and helping them navigate complex medical decisions with clarity and compassion. Welcome to the podcast, Dr. Sohn.
Thank you so much for the invitation.
You love managing medications and polypharmacy, and this is really your passion. So let's begin by first defining what is polypharmacy. What does that term mean in clinical practice, and how often do you see it in your patients?
Polypharmacy is taking 5 or more medications that include prescription, over-the-counter, or bought online supplements, vitamins, minerals, herbals, traditional, and complementary medications all combined. Mm-hmm. In the clinical practice, it can apply when a person is taking a medication with unclear or inappropriate reason, number, dose, frequency, duration, and even timing. In the United States alone, over 50% of adults 65 years and older have polypharmacy.
So 5 or more medications, and
Yes.
It doesn't have to be just prescription. It's any pill that you're putting in combination.
Yes.
Why does this happen so commonly in older adults? What drives these factors? Compared to a 20-year-old, for example, they're not on many medications, I would imagine, on average. Why more in the older adult?
The caveat and challenge in caring for our older adults is that multiple medications are often needed to manage different types of medical conditions that develop as we age. However, many of the national guideline-forming trials did not include our very older adults as participants. Hence, it is important to approach with caution whether the guideline can be applied to our very older adults. And our medical system is quite fragmented with multiple systems, specialists, clinicians, and pharmacies that do not communicate, which can contribute further to polypharmacy.
Yeah, so the more doctors that you see for a health condition, it's easy to add a pill or, get something treated without clear follow-up. And I guess that leads to my next question is, do you feel like this is perpetuated by the prescribing culture that we're seeing?
I notice as we are getting educated, at least when I was in training many years ago, that prescribing a medication means you're doing something for your patient. Mm-hmm. Rather than, let's see how this illness progresses, let's see how lifestyle helps you. That's less of doing something, so people are shy to watch and see.
Right.
However, there is no pill that can make us live forever. There is no pill that can fix and eliminate a chronic medical condition completely. Medications help to keep things under control. For example, we try to manage high blood pressure with lifestyle and medication to lower stroke, heart attack, and kidney damage risk. Staying physically active, eating well, not smoking, chewing, or vaping, no alcohol, remaining socially engaged, having a healthy sleep hygiene are pivotal to keeping our body and mind well. I hope we start to imprint the importance of lifestyle as a foundation to all medical management, and that medication is an addition to and not a replacement to lifestyle.
And then some people might assume that more medications simply means there's more problems that are being treated. Can you explain why that isn't always the case?
It actually may be unrecognized prescribing cascade. I also worry about a misconception. Just because one can buy a medication over the counter in the store or online does not mean it is innocent and safe. More medications may mean more side effects and increased risk of toxicity.
Right. Medication cascade. Can you elaborate on that? What does that mean?
Prescribing cascade occurs when an adverse drug event is erroneously perceived as a new medical condition, and another medication is started, which leads to a new side effect, and the domino effect ensues. I had a patient who started dance classes to lose weight. She became so achy and started taking ibuprofen every day. This was neither disclosed to her clinician nor asked by her clinician either. It was not in her medication list or in her chart. It led to high blood pressure. So a new medication was started, and it unfortunately led to leg swelling. So another medication was started for that leg swelling, and it led to side effects such as dehydration, electrolyte imbalance, and development of gout, leading to 3 more medications being started. So when a patient presents with what seems to be a new medical condition, I take a step back and ask myself, could it be an adverse drug event from a medication that's already being taken by the patient?
Yeah, that ibuprofen example is a very common one, and it's so easy to get that over the counter that people just assume it's safe to get. Same thing with sleep aids out there. You can't sleep. There's doxylamine, there's Tylenol PM, all sorts of things that you can take without knowing that there's a whole list of side effects to be aware of. I see prescription cascades all the time in our practice, and same thing. When someone's not doing well, not feeling well, new health issue, first thing is look at their meds, right?
Yes.
Always a good practice. Can you describe some of the other common complications of polypharmacy that you see in older adults?
I actually see quality of life and cost being a major concern.
Okay.
Their lives revolve around taking medications at a certain time throughout the day. Patients often say, "Doc, after taking all those pills, I don't feel like eating. I feel nauseous." This is a serious issue, for it can lead to malnutrition, which can cause bone and muscle mass loss, which becomes a threat to our aging adults' mobility and function. In addition, polypharmacy also increases risk for adverse drug events, drug-to-drug interactions, drug-to-disease interactions, trouble with medication adherence, healthcare utilization due to unrecognized side effects, cognitive impairment, physical impairment, functional decline, disability, and even mortality has been reported in studies.
Yeah, that's important to know because we typically think of polypharmacy as prescription drugs, but even if you're on no prescription drugs and you're taking a bunch of vitamins, herbs, supplements, that can have interactions too, and we don't realize what consequences those may have.
Correct.
For people who are listening and their caregivers, are there any other warning signs that someone may be overmedicated?
People who are at risk for adverse drug events are very older adults, 85 plus, women, people with low body mass index, creatinine clearance less than 50, poor liver function, 9 or more drugs a day. So if one medication is taken 3 times a day, that accounts for 3 out of 9 of the drugs that you take in a day. People with multiple medications, functional decline with falls, cognitive decline with confusion, physical impairment with poor hearing, vision, dexterity, the joint movement being limited health literacy, multiple prescribers and multiple pharmacies are at risk of being over-medicated.
Yeah, and to my earlier point is that if there's any change in your physical function or any change from your baseline, and it can just be even something very subtle, like I just feel more tired or I am more dizzy, all these contribute to fall risks, right? But if there's something that's just not normal compared to your baseline, something's off.
Yes.
And it could be your meds because every year our bodies change, our kidneys kind of slow down, liver doesn't clear things as effectively, so The medicines that we were on 20 years ago may not be as appropriate now. Let's talk about different types of meds now. Are there certain medication classes that you commonly see overprescribed or continued longer than necessary?
How much time do you have?
Oh, we can sit here all day as long as our listeners are okay with that.
Well, the United States Department of Health and Human Services issued a national action plan for adverse drug event prevention and deemed 3 drug classes as a high priority target. Number 1 is inappropriate use of anticoagulants, such as blood thinners. Number 2 is improper use of anti-diabetic agents, such as insulin. And third was opioids, tramadol and oxycodone.
Okay, so you've talked about blood, anticoagulants, anti-diabetic agents, and opioids. Are there any other drugs that can cause adverse events?
Other adverse drug event agents include anticholinergics, oxybutynin that we use for bladder, inappropriate use of antiplatelets such as aspirin, improper use of hypoglycemic agents such as glipizide, antihypertensives that can precipitously drop blood pressure, diuretics that lead to dehydration and electrolyte imbalance, drugs for mood that cross the blood-brain barrier, and lastly, benzodiazepines such as Ativan or Xanax.
And can you tell us a little bit more about how long-term use of benzodiazepines can potentially cause harm?
We are learning that long-term use of benzodiazepine medications lead to cognitive decline, imbalance, and fall. One note I do want to make is if a patient is in hospice, the concerns of these medications are no longer applicable because we are shifting our goal towards symptom control.
Right.
However, if you're otherwise a thriving adult, we must be very mindful of these medications.
I'm hearing a lot of antis, so anticholinergics, anticoagulants, and let's just break that down a little bit. Anticoagulants are typically in the blood thinner category. Antidiabetics, obviously lower blood sugar, and too low a blood sugar will lead to problems. Hypoglycemia is never a good thing. Can you explain anticholinergics? Why is that so harmful?
Anticholinergic agents actually cross the blood-brain barrier, and long-term use of that can impair your cognition, how your brain functions. It can cause dryness of the mouth, the gut. It can cause vision impairment, which is a threat to fall risk in our older adults, bladder not really moving, bowel not moving, and balance problems. So it is a very serious side effect.
Yeah, because it depletes an essential hormone in the brain, acetylcholine, which is something that is very critical and often depleted in conditions like Alzheimer's disease. I heard benzodiazepines, antidepressants and mood disorders, and that also crosses the blood-brain barrier.
Correct.
Can you explain that a little bit more as far as why things that cross the blood-brain barrier, why is that so harmful?
So as we get older, our body changes. We get more adiposity, a little more fat accumulation. So the fat-soluble medications cross throughout the body faster. What happens is the total muscle mass decreases, and muscle is an important system to actually process your medication. And also there's decreased blood flow to the nerve, to the kidneys, to the liver, and your blood-brain barrier that must be tight so that you don't get foreign invasion becomes relaxed when we get older. So the medications that cross that blood-brain barrier can have a higher side effect than benefit.
I think that's good to explain to our listeners that the things that go to the brain often are not as helpful. Why do some medications that perhaps helped earlier in life become riskier as patients age?
As we get older, we have more adiposity, fat accumulation, loss of muscle mass, less blood flow to nerves, kidneys, liver, and also another critical change is the total body fluid naturally decreases too, which is important to process medication. And as stated before, the blood-brain barrier becomes relaxed and more vulnerable by medications that affect the brain function. Our aging body changes how our body absorbs and processes medication, and it becomes difficult to predict how the drug affects our body due to all these factors. The pendulum may shift from benefit to risk.
How about over-the-counter medications? We talked about that a little bit in the beginning. People assume they are harmless, right? You can get them over the counter. They must be safe. But how do over-the-counter medications contribute to polypharmacy? And what are the cautions that we should be thinking about with over-the-counter items?
So over-the-counter medications can be bought in the store or online without a prescription. And the most common one that we see is oral NSAIDs, such as ibuprofen, Motrin, Advil, Aleve, naproxen. Long-term use of these medications can lead to leg swelling, blood pressure increasing, gut bleeding, kidney damage, and tinnitus, which is ringing in the ears. And if you happen to be taking any blood thinners, in addition, this really magnifies your risk of bleeding through the gut. Another class of anticholinergic agents you can get over the counter is for sleep, diphenhydramine, doxylamine, Benadryl, the PM medications, Tylenol PM, ibuprofen PM, as we discussed, impair cognition, vision, bladder, bowel, and balance. Another category is the herbs and supplements and vitamins, and they are not Food and Drug Administration regulated. Studies have shown they may add complexity and cost without improving mortality, heart, cancer, or cognitive function. They have potentially harmful side effects and serious drug interactions that are difficult to decipher.
Yeah. I think a good rule of thumb is if it's a pill of any sort, have some awareness that there could be harm, even if it's over the counter, even Tylenol.
Yes.
There's a dose limit to Tylenol that you can
Correct.
take it in a day. The vitamins, supplements, just be aware that they're not always 100% safe, especially if you're on other medications that could cause interactions. I'm hoping now we can shift into some solutions here and talk about deprescribing and understanding what that means. It sounds kind of self-explanatory, right? Deprescribing or getting rid of medications, but there is an art to it, and it's harder than we might think. Can we just start with the general benefits, and how does that process typically work?
Yes. I want to give you the definition of deprescribing.
Sure.
Deprescribing is medical care. It has three broad definitions. Number one, weaning off or stopping a medication because it is no longer indicated, safe, or because the condition has resolved. Number two, adjusting the dose, frequency, timing, and duration based on age, weight, liver function, and creatinine clearance. And number three, switching to a safer alternative with less side effect. The goal is to reduce adverse drug event.
So how do you start this, Dr. Sohn? When you are reviewing a patient's medication list and you're looking at something that's 25 items long, how do you determine which medicine is a good candidate to maybe start tapering or stopping? It just seems so chaotic to look at all that and decide, all right, which one do I start with?
I'll give you two broad categories of how I approach. Number one, I think about the geriatric 5Ms framework. Number one, what matters most to the person? How does my recommendation and medication align with the goals of that person? Number two, the mind. How does the medication affect the mood and cognition of the person who is sitting in front of me? Number three, mobility. Does the medication affect function, physical domain, and fall risk of the person in front of me? Number four, medication, which entails recognizing and addressing polypharmacy and prescribing cascade by deprescribing. And number five, multi-complexity. How does the medication interact with social drivers of health of the person? In a more clinical situation, I review, does each medication have a very clear reason to continue? is it actually helping the patient and fulfilling the purpose it is supposed to do? And if it is, then I ask, is the dose appropriate based on creatinine clearance, liver function, age, and weight? Is the timing right? How is it being taken? When is it being taken? With what are they taking it? And is the side effect becoming greater than the benefit? And is the cost becoming unbearable? These are the things I think about.
Dr. Sohn, that sounds like a 4-hour job there. I mean, as a seasoned geriatrician, you've been trained to do this and you approach this from a very clear lens. But for the average provider or a caregiver, how do they even begin to assess that? I mean, if there's something not right, if someone is not feeling well, how do we approach a medication adjustment according to those symptoms?
So usually there is some help. There's a clinician pharmacist you can always refer to. And also, the American Geriatric Society has Beers criteria.
And just for our listeners, the Beers criteria is a guideline that lists potentially inappropriate medications for adults age 65 and older to improve safety and hopefully reduce adverse drug effects.
Correct. There is start and stop criteria as well. And I start targeting the ones that are high risk. That's going to affect the mood, the cognition, the function of the person. And there are many medications patients don't even know why they're taking. And if we don't know, it's a good time to say goodbye to that medication.
Yeah, so that's a good point, is asking which one of these medicines you've been on for a long time, is it even helping, is a good question to start. And if they're having symptoms like, I'm coming in dizzy, my blood pressure's in the 80s, well, maybe they don't need to be on all their antihypertensive. So these are kind of low-hanging fruit ways we can just quickly look at the patient in front of us, what's going on, and then find the offending agent that could be making things worse for them. How do factors like frailty, overall health status, one's life expectancy influence your deprescribing decisions?
So I've accepted early on in life that death and life are a flip of a coin, and it's the destiny of all mankind. So when the time comes when the patient seems to be entering the last chapters of their life, or they're having recurrent acute illnesses that are becoming difficult to manage, then I start having a discussion about where are we? Where do you understand we are at? And I start addressing every medication. Is this medication actually going to help you, or is the side effect going to be more eminent and harming you, is how I approach. Every medication takes time to see the benefit. And if you are having 6 months or less time to live, and we start a medication that takes years to see benefit, that doesn't make sense to continue.
That's
so
true.
I start addressing one at a time. Is it helping you? Is it beneficial? Is it helping you feel well? If so, let's make sure it's adjusted according to your body's current condition. And if not, can we talk about what can we stop?
Right.
So that we can reduce pill burden and the cost, which really does add up.
And perhaps the medication use at that juncture is more for improving their quality of life, whether it's pain or other symptoms that's really impacting their day-to-day living.
Correct.
How do you work with patients who have troubles perhaps stopping their medication, who may express fears or uncertainty or a little bit of hesitancy with their medicines? Doc, I've been on this for 20 years. I really don't want to rock the boat. I don't want to change. How do you address those concerns?
That is one of the geriatric 5M's framework, the what matters most and medication. Majority are thrilled to stop it, but minority I have met who are afraid of deprescribing and even equating it to abandonment. So I stop and listen. What is worrying you? What is causing you to have fear of stopping these medications? I stop my goal of deprescribing or stopping and simply nurse their emotions. And then I hear where they're coming from. And I share my thoughts and hopes by doing deprescribing. I'm hoping to keep their mind sharp so they can preserve their function by adjusting medications that can be harmful to them. And in the end, sometimes we may need to continue what is considered high-risk medications. So what I do is I educate and empower the patient and care partners. This is what we are planning to continue. Please watch for the development of these side effects. And if you start noticing, please note this is your body telling us it's time to say goodbye to these medications.
Sure. And when you go through that process of reducing or stopping medicine, what does the aftermath look like? What does the monitoring process look like for you?
If it's a very high-risk medication with withdrawal risk, I have a follow-up within a few weeks. However, if it's a routine medication, supplements, vitamins, I give it a good few months even for it to wash out of the body and have them come back. A lot of the patients are very thrilled because they have not noticed any difference in how they feel, and they have more confidence in saying, what else can we stop now?
Yeah, there's easy ones to stop and there's harder ones to stop, right? It's pretty simple that if your blood pressure is low, you probably shouldn't be on your blood pressure medication. You stop that right away, not have to wean too aggressively, and that should be okay. But with opioids or other medicines that affect our cognition, that typically needs to be a little bit more thoughtful.
Yes, very slow and steady. In the geriatric mantra, we have start low and go slow. Whether you're starting a medication or stopping a medication, take it slowly and go with the pace of the patient.
Right. So then how do you know when you've reached the right balance and the whole deprescribing process is complete, so to speak? Like, when do we say, all right, this is a job well done, we're good to go here?
In the end, I ask, is this medication, whether low, average, or high-risk medication, is it actually helping you? Serving its purpose? Is it really beneficial and making you thrive and function? If the answer is yes, I do continue it with the caveat of seeing them at least once a year to make sure the side effects are not taking over the patient's life. Slow and steady. I had a patient who was on 50 medications, 50. Over the years, many prescribers with good intentions kept adding whenever she mentioned a symptom rather than reviewing her medications. And when she brought all her bottles, prescription, supplement, herbal, what have you, there were so many duplicates of similar medications, and she was falling, confused, and it took us almost 2 years to get down to 20 medications. It was a slow process because she was withdrawing at times too.
Yeah. And even 20 sounds like a lot, but you were able to cut back quite a bit to the sort of the bare minimum that still allowed her to live a good quality of life and treat whatever health issues that they have. You know, we don't want to stop everything, especially if they still have heart disease or diabetes.
Correct.
I mean, stopping all that would cause harm, right? So there are a bare minimum that probably still would be very helpful.
Correct.
Yeah. I would add that for me, I don't ever feel like there is a completion. I think completion for me would be like no meds at all. But that may not be right either. And what I would say is that there's no completion because every time we see a patient, we should always do a medication review. And that is the goal each time, is that we never stop reviewing. Even if it looks like there's nothing on the med, let's still take a look. And that is the duty that we have to make sure that our patients are prescribed things safely and that we are continuing to monitor things. And that's part of the deprescribing process.
I agree with you. When I have a patient who has 0 medication on the electronic medical record, I start giving names of over-the-counter medications and supplements and vitamins, and then 10 medications are on the list now.
So let's offer some practical advice for caregivers and help counsel people on safe medication use, how they can screen and deal with polypharmacy. How can people start a productive conversation with their provider about their medication use?
I think 3 opening lines would be fine. I would like to take time to review my medication bottles with you. I'm worried about the number of medications I'm taking. I'm getting worried about the potential side effects of all the medications I'm taking. And I would encourage people to actually dedicate the visit only to medication review because that alone can sometimes be more than one visit.
And what are some practical habits that people can adopt to keep their medications maybe safer or more manageable to use?
I recommend to have one dedicated pharmacy if able.
Yeah.
And ask your specialist who is out of network of your primary care clinician to fax their notes so the chart can stay up to date. Keep a medication list with the name, the dose in milligram, microgram, international unit, frequency, how you take it, when you take it, with what you take it in your purse at all times. And schedule a medication review with your primary care clinician or clinician pharmacist at least once a year, ideally with all your bottles.
There's also safe boxes where higher risk medicines like oxycodone and other narcotics are stored safely so they don't get lost or stolen. And you've already shared several great patient stories, but can you think of any success story that really jumps out at you that you think about from time to time where Deprescribing made a very meaningful difference to their quality of life?
I had a lady in her 90s whose thyroid medication dose was extremely high. So I asked her, how are you taking this medication? When are you taking the medication? And with what are you taking this medication? She was taking her thyroid medication with her iron pill, her calcium pill, her vitamin D, with breakfast, with coffee and creamer and milk, which thyroid binds to all of these. Hence, I educated, let's try. I know it's a little cumbersome. As soon as you wake up with a glass of water, take your thyroid medication. Thereafter, get ready for your day and take your breakfast and all your other medications. Soon after, we were able to slowly come down to the lowest effective dose, and she did just fine. Another one is, I had a lady who took a mood medication at nighttime, and it led to restless leg syndrome, insomnia, and also headache. So she was given 3 additional medications for each of these side effects. So I asked her to start taking it in the morning, and she was surprised. She actually felt better, and we were able to come off the 3 prescribing cascade medications. And lastly, I had an 80-year-old woman who came in with all her bottles. She said, no one's ever told me to do it. I felt like a pharmacy. I thanked her for bringing it all in. And she had none of her supplements in the medication list. There was over 10. And we went through, how is this helping you? How do you find it beneficial? And she said, oh, someone from television said it was good. She read it in a magazine. Someone said it in passing. So we were able to stop everything but one, and she was a very happy person leaving because they were adding up in cost.
I think you've changed a lot of lives, Dr. Sohn, just by reviewing someone's medicines and getting them off things that they shouldn't be, or just switching things around a little bit. I can't tell you how many times people have done better just by getting rid of Tylenol PM.
Yes.
My gosh. Or Benadryl. I mean, they can't sleep, so they just take something over the counter to sleep. Then they're groggy during the day. They've got brain fog. They can't concentrate, and they think they're getting dementia. And you just get rid of that, and they've got their lives back. And then we work on sleep hygiene and other things for the initial problem. But if we can reach thousands of people today, just be careful of that diphenhydramine. So anything with a PM over the counter, be very cautious with that. I mean, obviously, you've got history of bad allergies and you've taken Benadryl for a long time for that. You were able to handle it when you were younger. With time, with aging, it becomes a lot harder to tolerate that. So just to be aware. Do you see any changes in the healthcare systems that suggest we're maybe doing better on this, or are we improving how we address polypharmacy?
I am seeing a glimmer of hope.
Okay.
More papers and national conferences are starting to address polypharmacy outside the geriatric medicine world. Our electronic medical record here at Mayo Clinic has an alarm that goes off when a high-risk medication is about to be prescribed and suggesting alternatives. And at Mayo Clinic, we teach our medical students about the geriatric 5Ms throughout their education. And I hope our medical system continues to evolve to recognize and address polypharmacy.
And when we're thinking about just aging well as a whole, how does that thoughtful medication use fit into the bigger picture of healthy aging? Because I think that's something we don't talk about much in most longevity conversations, is we think about ways to extend our life expectancy, but we don't talk about the things that we're taking
When there's a clear indication, we certainly hope the medication helps to lower the risk of complications by controlling those chronic illnesses, such as type 2 diabetes mellitus, heart failure, history of stroke, etc. The bigger picture I ask is, how can we change and modify our lifestyle to optimize the geriatric 5Ms? Being mindful of the aging body, how the medication is being processed by the aging body, and what the medication does to the aging body, being mindful of that. In the end, the question is, does it help the person function, feel well, and thrive?
And we do have one closing question for our guests, Dr. Sohn. What does aging forward mean to you? And how do you personally age well?
I believe a person can age well by faithfully working on lifestyle, healthy lifestyle with joy.
Yeah.
To me, aging forward means accepting my changing body, mind, and soul with gratitude and grace because I trust God is the strength of my heart forever.
So as we've learned from Dr. Sohn today, Deprescribing isn't about taking things away. It's about aligning care with what matters the most, with safety and clarity and quality of life. And so aging forward means asking those questions and staying informed and partnering with your care team to ensure that every medication, like you said, has a purpose, right? So thank you so much for reminding of us today. And it was wonderful to have this conversation with you.
Thank you so much for having me.
For our listeners who are wondering whether their medications are still the right fit, here are 3 simple but powerful questions you can ask your doctor. Number 1, do I still need every medication that I'm taking? Because health conditions can change, or medications may no longer be necessary over time, so it's very reasonable to ask if any of your prescriptions may be reduced, substituted, or safely stopped. Number 2, could any of my medications be interacting with each other or causing side effects? Symptoms such as fatigue, dizziness, appetite changes, confusion, and falls, anything that's different than your baseline can sometimes be medication-related. So reviewing potential interactions is especially important if you see multiple specialists. And number 3, what medications should we consider deprescribing first? I think your doctor would love to have this conversation with you because not every medication may need to be taken forever. So ask your provider which ones might be the safest to taper or reassess and how to monitor your health during the deprescribing process. So that's all for this episode. Hopefully you're feeling a little bit more informed, inspired, and empowered. If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272, and we might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.